Think about the sheer power and resilience of the human heart, constantly pumping life through us. But what happens when that main exit valve starts to narrow, creating a bottleneck?
Yeah, real problem.
Today on the Deep Dive, we're tackling exactly that, aortic stenosis. And for you, our listener diving into MSRA prep, this is definitely a high-yield area you need to know.
Absolutely. It comes up.
Our mission, to really extract the core exam-relevant knowledge from your revision notes on aortic stenosis and just make it stick.
Exactly. You've got those MSRA revision notes packed with detail. We're here to help you sort of navigate the key bits, the definition, causes, how we spot it, what we do, in a way that's clear and hopefully easy to recall for the exam.
Okay, let's jump right in then. What exactly is aortic stenosis? Define it for us.
So in simple terms, aortic stenosis means a narrowing of the aortic valve. That's the valve letting blood flow out from the main pumping chamber, the left ventricle, out to the rest of the body. And your notes point out, quite rightly, it's often down to calcium buildup on the valve leaflets. It can happen right at the valve or sometimes above or below it.
And that causes a murmur.
Yes, that's the telltale sign, that ejection systolic murmur you'll learn to pick up on examination.
Got it. A narrowing causing a specific murmur. Now, what are the common culprits? What causes this narrowing?
Well, we can split the causes into two main camps. Congenital, meaning you're born with it, and acquired, which develops later on.
Right.
Congenitally, the big one is a bicuspid aortic valve. So 2 leaflets instead of the usual 3.
Ah, okay.
You definitely need to think about this in younger patients, and it's actually more common in men. These valves, well, they don't open and close as efficiently, leading to more turbulent blood flow. Over time, this causes scarring, fibrosis, and eventually calcification.
Makes sense.
The memory tip is handy for 2 cusps, often showing up before someone gets really old.
Good one.
Also in that congenital group is Williams syndrome. That can cause supravalvular stenosis so narrowing above the valve itself. Think, will super surprise you above.
Congenital covered. What about the acquired causes? What drives it later in life?
So the most common acquired cause by far is degenerative, sometimes called senile calcification. This is basically wear and tear on a normal 3-leaflet valve.
Just getting older.
Pretty much, typically seen in older adults, usually over 65. And interestingly, while bicuspid valves are more common in men, this degenerative type is actually more prevalent in women.
Oh, interesting.
Then you've got autoimmune causes, mainly rheumatic heart disease. That stems from a group A strep infection causing inflammation that damages the valves.
Right, the post-strep complication.
Exactly. And finally, there's hypertrophic obstructive cardiomyopathy, HOCM. That can cause a subvalvular stenosis, so narrowing below the valve.
Okay.
Your notes give that useful mnemonic DS for the acquired causes, degenerative, autoimmune, subvalvular.
DOS. Got it. So different origins, and you also mentioned classifying by location, valvular, subvalvular, supravalvular.
Precisely. Valvular includes the bicuspid valves, the senile calcification we talked about, rheumatic disease, even significant atherosclerosis hitting the valve. Subvalvular is mostly HOCM, and supravalvular, like we said, links back to Williams syndrome and that hypercalcemia connection.
Right.
And crucially, we need to touch on aortic sclerosis. It sounds similar.
Yes, sclerosis. What's the key difference there? Important for exams, I bet.
Definitely important. Sclerosis is kind of like the precursor, an earlier stage of that valve degeneration. You do get an ejection systolic murmur, like in stenosis.
Okay.
But, and this is the key, it typically doesn't radiate anywhere, not to the carotids in the neck or the axilla. Plus, the pulse character and the second heart sound, S2, they're usually normal in sclerosis.
No radiation in normal pulses too. Got it. That's a clear distinction.
It really is, something examiners like to test.
Okay, so sclerosis is milder. What puts someone more at risk of developing the full-blown stenosis?
Well, the risk factors aren't too surprising. They overlap a lot with general cardiovascular risk. Things like older age, high blood pressure, smoking, diabetes, high cholesterol. Oh, and chronic kidney disease, too.
Standard stuff, mostly.
Yeah. Your notes have that other mnemonic, SHEDC. Smoking, hypertension, elderly, diabetes, cholesterol, chronic kidney disease.
SHEDC. Handy. Okay, let's dig into the mechanics. What's actually happening inside the heart when that valve narrows? The pathophysiology.
Right. So the core problem is that obstruction to blood flowing out of the left ventricle. This forces the LV pressure to go way up because the ventricle is working much harder to push blood through that tight valve.
Okay.
To cope with this extra workload, the muscle wall of the left ventricle gets thicker. We call that left ventricular hypertrophy, or LVH.
The heart bulks up.
Exactly. And it's that pressure difference, the gradient across the narrowed valve, that generates the ejection systolic murmur we hear.
Makes sense.
Now, something really important to grasp is why these patients get angina or chest pain. It seems a bit counterintuitive sometimes.
Yeah, why is that?
It's because that prolonged forceful contraction phase systole actually shortens the relaxation phase, which is diastole. And the coronary arteries, the ones feeding the heart muscle itself, they fill mainly during diastole.
Ah.
So you've got a shorter filling time for the coronaries, plus you've got this bigger, thicker heart muscle that needs more oxygen. It's a supply and demand mismatch.
Less supply, more demand leads to pain.
Precisely. And ultimately, if this whole process goes unchecked, the heart muscle just can't keep up, and it starts to fail. You end up in heart failure.
A grim progression. How common is this condition?
It's actually the most common valvular heart disease in places like the US and Europe. Really common.
Wow.
And its prevalence shoots up with age. Your notes say around 10% of people over 80 have it to some degree.
1 in 10 over 80.
Yep. So typically people present in their 70s or 80s, but remember, those congenital forms, like the bicuspid valve, can cause trouble much, much earlier. And there's a definite male predominance, about 4 to 1.
Okay, so we're likely to see this, especially in older patients. What are the key symptoms and signs we should be looking out for in clinic or on the wards?
Often, the very first thing people notice is getting short of breath when they exert themselves, maybe climbing stairs, walking uphill.
Okay, exertional dyspnoea.
Exactly. As it gets more severe, you might see the classic triad emerge. Chest pain, like that angina we discussed, shortness of breath, often linked to developing heart failure, and dizziness or even fainting, syncope or pre-syncope, especially when standing up or exercising.
The triad. Pain, breathlessness, fainting.
Right. Though we'll come back to how classic that triad really is. Other things can include fatigue, just feeling wiped out. That can be big in children too. And sometimes less specific things like nosebleeds or easy bruising can pop up.
And on examination, what are we listening for, feeling for?
The absolute key sign is that ejection systolic murmur. Loudest over the aortic area, second right intercostal space. Usually and crucially, it radiates. Typically up to the carotid arteries in the neck, sometimes to the armpit, the axilla.
That radiation is important.
Very. It has that crescendo decrescendo shape, like a diamond shape if you plotted its intensity. Builds up, then fades away. And it usually gets quieter if the patient performs a Valsalva maneuver.
Okay, what else?
You might find signs of a low cardiac output state. If heart failure is setting in, you could hear crackles in the lungs, pulmonary edema. The pulse is often characteristic too. A narrow pulse pressure, and it feels slow rising, weak, and delayed. That's pulsus parvus intardus.
Slow and late pulse.
That's it. In severe cases, the second heart sound, S2, can become soft or even disappear altogether. You might hear an extra heart sound, an S4. And if there's significant LVH, you might feel a vibration, a thrill, or a heave over the apex beat, though the apex itself usually isn't displaced, unlike in some other conditions.
Right.
Oh, and if it's a bicuspid valve causing it, you might hear an ejection click just after the first heart sound. Plus, you could find other signs related to the LVH itself, or complications like pulmonary hypertension or AFib.
You mentioned the classic triad isn't always so classic.
Yeah, it's important to realize that while we talk about chest pain, shortness of breath, and syncope as the triad, your notes point out it's only actually present in maybe 30–40% of patients under 50.
Okay. So not everyone reads the textbook.
Exactly. Many people can be asymptomatic for a long, long time. Often symptoms only really start when the valve area is reduced by more than 2/3, so quite significantly narrowed.
That really highlights why investigations are so critical, doesn't it? Catching it before it gets too severe.
Absolutely. You can't rely on symptoms alone.
So what are the key tests? What do we order?
Well, you start with the basics, obviously. Observations. Heart rate, blood pressure, O2 sats. Then blood tests are important. FBC, UNEs for kidney function, LFTs, clotting screen. Maybe a troponin if chest pain is a feature to rule out ischemia.
Standard workup. What about the ECG?
The ECG can give some really useful clues. You might see signs of left atrial enlargement P matrial, definite signs of left ventricular hypertrophy, LVH, those deep S waves in V1, V2, and tall R waves out laterally in V5, V6.
The voltage criteria.
Right. And often an LV strain pattern goes with it, ST depression and T-wave inversion in those lateral leads. You could also see things like left bundle branch block or AV block if the calcification is extending into the heart's electrical system. That might mean needing a pacemaker down the line, maybe left axis deviation, poor R-wave progression.
Lots of potential ECG signs.
Yeah, the mnemonic PEL-LL might help. P-mitril, enlarged R deep S for LVH, strain pattern, left axis, or LBBB.
PEL. Good one. Okay, ECG can be suggestive, but what's the definitive test, the one that really nails the diagnosis and tells us how bad it is?
Without a shadow of a doubt, that's the echocardiogram. Echo is absolutely key way.
Okay.
It lets us actually see the heart, see the valve leaflets moving, assess how thick the ventricle walls are, how well the LV is pumping the ejection fraction, and critically, it lets us measure the pressure gradient across that narrowed valve and estimate the aortic valve area.
So it confirms it and grades it.
Exactly. Those measurements are essential for figuring out the severity. Sometimes a transesophageal echo, a TE, is needed for a closer look, but usually the standard transthoracic echo is enough. Doppler techniques within the echo are vital for measuring blood flow velocity, which helps calculate that gradient accurately.
And those severity grades are exam gold dust, right?
Absolutely crucial. You need to know these numbers. Your notes lay them out clearly. Mild AS is a mean gradient under 25 millimilli Hg, valve area over 1.5 centimeters squared.
Yeah.
Moderate is a gradient of 25 to 40 millimilli Hg, area between 1 and 1.5 centimeters squared.
Right.
Severe is where the gradient is 40 to 80 millimilli Hg, and the valve area is less than 1 centimeter squared. And then very severe is a gradient over 80 with an area less than 0.5 centimeters squared.
Mild 25, mod 25-40, severe 40-80, very severe 80 for the gradient.
Got it.
Nail those down. They often form the basis of questions on management.
Makes sense. Are other imaging tests used, like X-rays or MRI? Yeah, they have roles. A chest X-ray might be normal early on, but later it can show cardiomegaly from the LVH, maybe signs of heart failure, like pulmonary edema. Sometimes you can even see calcium in the aortic valve ring or a dilated ascending aorta.
Okay.
Cardiac MRI and CT give more detailed pictures of the heart structure. Cardiac CT is particularly good for measuring the amount of calcium in the valve, which has prognostic value, and also for checking the coronary arteries before potential surgery.
And catheterization. Angiogram.
Yeah, cardiac cath is usually done before any surgery. It gives very precise pressure measurements across the valve to confirm severity and, importantly, checks for any blockages in the coronary arteries that might need dealing with at the same time.
Right, concurrent CAD.
Exactly. And finally, exercise stress testing ECG on a treadmill can sometimes be useful, maybe to unmask symptoms in someone who says they're asymptomatic or see how their blood pressure responds. But you have to be cautious. It's generally contraindicated if someone already has significant symptoms unless it's done in a very controlled environment. Risk of syncope.
Right, makes sense. Okay, so we've investigated, we know how severe it is. How do we actually manage aortic stenosis?
Management really depends heavily on whether the patient has symptoms and also a bit on the underlying cause and the severity.
Okay.
Medically speaking, there aren't really any drugs that can halt or reverse the valve narrowing itself. That's a key point. Medical therapy is more about managing the consequences.
Like heart failure.
Exactly. So diuretics for fluid overload, maybe digoxin in some cases. But you have to be careful. Things like nitrates, which lower blood pressure, can actually make things worse in severe AS by reducing preload too much. So lots of contraindications to watch out for.
So mainly supportive care medically.
Pretty much. Plus, managing all those other cardiovascular risk factors, blood pressure, cholesterol, diabetes, and sometimes antibiotic prophylaxis before certain procedures to prevent endocarditis, though guidelines on that change, so always check.
And monitoring. Just watch and wait if they're asymptomatic.
Regular monitoring with echo is crucial, yes. If someone has severe AS but no symptoms, they'll likely need an echo every 6 months or so. Mild or moderate AS, especially if there's valve calcification, probably annually. We watch closely for symptom development or worsening severity.
Okay, but if they are symptomatic or it's severe, then it's surgery.
Then surgery or another intervention becomes the main consideration. That's the definitive treatment if it's significantly symptomatic or severe.
Right.
Surgical aortic valve replacement, AVR, is the traditional gold standard for severe symptomatic AS. It definitely improves quality of life and survival.
Replacing the whole valve.
Yes. There's also balloon aortic valvuloplasty, using a balloon to stretch the valve open. It can provide temporary relief, but the valve tends to narrow down again pretty quickly. High restenosis rates. So it's usually reserved for patients who are too unwell for surgery as a bridge, or sometimes in children if the valve isn't heavily calcified.
Okay. And the replacement valves themselves, they're different types.
Yes, broadly 2 types. Mechanical valves made of metal or carbon, They last a very long time, potentially a lifetime.
A downside.
Lifelong anticoagulation is needed, usually with warfarin, because blood can clot on the artificial surface. So these are often preferred for younger patients who can manage the anticoagulation.
Okay. And the other type?
Bioprosthetic valves made from animal tissue, usually pig or cow valves. The big advantage is they don't typically require long-term anticoagulation. They don't last as long, maybe 10, 15 years, sometimes longer, sometimes less, before they might degenerate and need replacing again. So they're often chosen for older patients.
Mechanical for young, bio for older, generally speaking.
That's the general rule of thumb, yeah. And the replacement can be done via traditional open heart surgery, or increasingly using a less invasive approach called TAVI transcatheter aortic valve implantation.
TAVI.
Yeah.
We hear a lot about that now.
Yes, it's become very common, especially for patients considered too frail or high risk for open surgery.
So how do you decide? AVR versus TAVI. What are the indications?
So the main indications for traditional AVR are severe symptomatic AS or even severe asymptomatic AS if the gradient is very high, say 40 millimole Hg, and there's evidence the left ventricle is starting to struggle, LV dysfunction. Also, if someone has moderate or severe AS and is having other heart surgery anyway, like bypass grafts, you'd often replace the valve at the same time.
Makes sense to do it all at once.
Right, and sometimes even in younger, low-risk patients with severe asymptomatic AS, AVR might be considered to prevent future problems.
Oh, okay. And TAVI, who gets that?
TAVI is primarily for patients with severe AS who are deemed not suitable candidates for open surgery or are at intermediate or high risk for it.
The less invasive option for higher risk patients.
Exactly. It involves inserting a new valve via a catheter, usually through an artery in the leg or sometimes the chest, guided by echo and X-ray. First, they often do a balloon valvuloplasty to open the way, then deploy the new valve inside the old one.
Clever stuff.
It is, and studies show it's much better than just medical management or balloon valvuloplasty alone for these higher-risk groups. But TAVI isn't risk-free either.
What are the potential complications with TAVI?
The main things to be aware of are bleeding, stroke or mini-strokes, TIAs, heart attack, MI, serious heart rhythm problems, damage to the aorta itself like dissection, cardiac tamponade, and sometimes the new valve doesn't seal perfectly, causing what's called a paravalvular leak.
Okay, still significant potential issues. This all sounds quite serious if left untreated. What's the general outlook, the prognosis?
It is serious. Aortic stenosis is a progressive disease. It generally worsens over time as that LVH develops and eventually fails. The prognosis definitely takes a downturn once symptoms like syncope or dyspnoea appear.
How bad is it then?
Without surgery, the survival for severe symptomatic AS is pretty poor. Your notes mention roughly 50% mortality at 18 months. Once symptoms start, the average survival without valve replacement is often quoted as about 5 years if it's angina, 3 years for syncope, and only 2 years if heart failure or significant dyspnoea develops.
Wow, those are stark numbers. Really underlines the need for timely intervention.
Absolutely. Valve replacement makes a huge difference.
And finally, what are the main complications we need to watch out for, besides the progression to heart failure?
Well, besides the LVH and heart failure we've discussed, complications include arrhythmias like AFib or ventricular arrhythmias, myocardial infarction. An interesting one is acquired von Willebrand disease, which can cause bleeding.
Really? How does that happen?
It's thought the high shear stress across the narrowed valve breaks down the von Willebrand factor multimers. Also, stroke is a risk, infective endocarditis infecting the damaged valve, complications from the surgery or TAVI itself, and sadly, sudden cardiac death is a known risk, especially in symptomatic patients.
A lot to be aware of. Okay, so just to quickly summarize the key takeaways for our listeners studying for the MSRA. Aortic stenosis. It's that narrowing of the aortic valve.
Right, often from bicuspid valves congenitally or age-related calcification later on.
Symptoms are classically chest pain, shortness of breath, syncope, but remember, not always present as a neat triad and often absent for a long time.
Exactly. And the echo is your #1 tool for diagnosis and grading severity. Know those gradient and area numbers.
And management. Medical is supportive, but for significant or symptomatic disease, it's about valve intervention.
Yes, AVR or TVI being the definitive treatments that really impact prognosis.
Brilliant. A really clear run-through. And remember, for more high-yield revision resources, practice questions, all aimed at helping you pass the MSRA, do head over to passthemsra.com and also check out freemsra.com.
Definitely worth looking at. Understanding aortic stenosis properly, how to spot it, grade it, manage it is vital, not just for exams, but for making a real difference to patient outcomes.
Couldn't agree more. Early recognition and appropriate management are key.